Good morning. I'm John Urbans, President and CEO of Greater Fort Wayne, Inc. Thank you for joining us today for our latest webinar, COVID Vaccines, What You Need to Know. We are presenting this webinar today with the Allen County Department of Health. As you know, the Allen County Department of Health has been at the forefront of fighting COVID-19 for the past year. I would personally like to thank them for their dedication that they have shown and the resiliency in their work that they've done. This webinar is being recorded and a link will be located on the Greater Fort Wayne Inc. website later this morning. Following the webinar, you will receive a survey via email to provide us with feedback on the event. Thank you for submitting questions ahead of time with your registration. We've incorporated many of those questions into the presentation, but we'll also be utilizing the Q&A function located at the bottom of your screen. Today's presenters will be Dr. Matthew Sutter, the Allen County Health Commissioner, and Mindy Waldron, the Health Department Administrator. They will be talking about vaccine development, how the vaccine works, and the county's vaccination plan. I'll now turn the program over to Dr. Sutter.
Thanks, John. Good morning, everybody. So I'm Matt Sutter, and as John said, I'm the Allen County Health Commissioner. Just a little bit about me. I'm an emergency doctor by training, and so my challenge today is to take about 2 years worth of science and compress it down into a 10-minute lecture. I would really recommend, first of all, I'm not a researcher, I'm not a virologist, I'm not an immunologist, so I'm not a true subject matter expert in those things. What I am is a physician who's been reading a lot about this and listening to a lot about this and learning a lot. If you're interested in that, I would encourage you to dig in. I love Coursera, online courses, and I really love the podcast This Week in Virology. They do a great job. It's awful sciencey and awful nerdy, but boy, you can get a ton of information. It's long form, it takes a long time, but it's good stuff. So, Mindy, if I get my first slide. So what I find when I talk to people is that many people don't have a good understanding of how vaccines work. And a lot of the questions come from kind of some basic misunderstandings. So what I want to try and do is, again, take 2 years of biochemistry, virology, immunology, and pack it down into 10 minutes. And we're going to do that with about 6 pictures. I'm going to start with how viruses work. I'm going to talk a little bit about SARS-CoV-2. SARS-CoV-2 is the virus that causes COVID-19. It's kind of the same thing as HIV and AIDS. One is the disease, one is the virus. Talk a little bit about the immune system, how that functions. Talk specifically about mRNA vaccines, which are the 2 that are currently approved in the United States. I'll talk a little bit about development and testing, and then go through a couple of quick questions, and we'll do that real quickly. If I get my next slide, Mindy. So let's talk about how viruses work first. So viruses are really interesting. One of the first things that I think a lot of people don't know is that viruses aren't alive in any real sense. They don't create their own energy. They don't make their own stuff. All viruses typically are is a bit of genetic material, either DNA or RNA, wrapped inside typically a lipid envelope. Doesn't always like that, but a lot of them are. So it's basically like a little shell with some genetic material inside, and that's all it is. It really can't do anything by itself. It's incredibly simple. But they've been tremendously successful, and there are millions of viruses, and there are, I think, somewhere on the orders of trillions or more viruses actually in the ocean, everywhere throughout our body. They attack bacteria, they attack all kinds of living things. They are truly part of our world and part of our environment. So this is a picture of how influenza actually acts. And this is typical for most viruses. So what happens is, you see in the top left, the virus basically attaches to a living cell. In this case, an epithelial cell or a skin cell. What it does then is it merges in and comes into the cell itself. That's what you see in part 2 there. And cells do this for other reasons, but the virus now gets inside. What happens then is it opens up and releases that genetic material, which is what you see in 3. Then it actually co-opts the cell itself. So the cells of our body actually become little factories that then replicate. They basically act like a giant copy machine to make copies of all the genetic material that's inside the virus itself. This is how a cell becomes infected with a virus. And then they actually use the cell to build a new envelope to put around the virus, creating more copies, just like a copy machine inside the cell. And then typically they will, or then they'll be released. Sometimes this is by the cell dying. The cell will basically burst and let loose, thousands or millions of new viral copies. Sometimes they'll break through the wall of the cell itself. There's a couple different ways that can happen. But now all of a sudden, where you started with one influenza virus coming into a cell, you're now left with hundreds or thousands of millions, depending on the virus itself. But again, the virus is not doing this. All the virus is doing is showing up and giving a blueprint and co-opting the cell into a factory to make more virus. And that's what viruses basically do. They just replicate themselves and they make more virus. Next slide, please. So now let's look at SARS-CoV-2. So SARS-CoV-2 is obviously what we're interested in. It is the virus that causes COVID-19. And it's an interesting virus. First of all, the genetic material that inside it is RNA. So it can be DNA or RNA. In this case, it's RNA. There's a number of other RNA viruses, some of which can be very deadly, like Ebola, for instance, is an RNA virus. In this case, it's a very long chain. So when we hear about these mutations, one of the things that's important to know is that the RNA chain is actually 30,000 links long. That's incredibly long for a virus. And so when you hear about mutations, there's currently several thousand point mutations, which means one of the links on the chain has changed in some way. That's on a 30,000 link chain. That's important to understand. And a lot of them are on the header and the footer, the ends of the chain, which aren't really a part of the replication. They're kind of just extra space. So when we hear about mutations, all viruses mutate. They mutate all the time. SARS-CoV-2 actually mutates relatively slowly compared to other viruses, like, for instance, influenza. And partly because it has a proofreading gene. It actually does a pretty good job of maintaining itself. However, we'll talk a little bit more about the mutations and the one that's getting a lot of press a little bit later. So this long chain of RNA, this long chain of genetic material that's kind of all coiled up in the center. And then there's a fat envelope around the side. There's basically 2 layers of fat. It's one of the reasons why soap works so well. As you can imagine, soap dissolving a fat, yeah, that's exactly what it does. And then on the outside of those layers of fat, there are these proteins. And there's 3 basic proteins that are seen on the outside. The membrane protein, the envelope protein, these are not talked about and are not that important. And then the spike protein, which I think everybody has heard about. The spike protein is what gives coronaviruses their name. It means crown. And they're like a bunch of crowns sitting on the outside of this shell. So when you look underneath the electron microscope, that's kind of the most notable feature on the outside. The spike protein is what this virus uses to actually attach to cells and then to enter the cells. And as a result, it's a key part in how it replicates. And all the viruses that are approved and the vast majority of the vaccines that have been developed. So the vaccines are all attacking that protein. Vaccines will target typically a protein and sometimes multiple proteins. When the body sets up immunity, it actually sets up immunity to multiple proteins. So it'll identify the membrane protein and the envelope protein and inside the nucleocapsid protein, in addition to spike. The vaccines only attack the spike, but it turns out that we got really lucky because it looks like that's a great target. Like this probably is going to have a hard time mutating out of that very large spike protein. Next slide. So then the immune system. So first of all, the immune system is complicated. In fact, if you ask an immunologist a question about the immune system, they'll almost always start with, well, the immune system is complicated. And what they mean by that is it's freaking incredibly complicated. There are so many things that go on, and there are so many processes that interact with each other and provide both positive and negative feedback that it's almost impossible to visualize. So even if you spend years studying it, the most common answer to a question about why something happens in the immune system is it's complicated. But I'm going to try and take an incredibly simplistic view, which is think about it as two different kinds of cells, the B cells and the T cells. And you'll hear about this sometimes when you hear about the vaccines. And in general, gross simplification, if anybody out there is an immunologist or knows much about this, they're probably throwing stuff at their screen right now. But in very, very simple terms, the B cells make antibodies and the T cells attack infected cells. Now, the T cells do a lot more. They've got a modulating effect. They've got, I could spend an hour just talking about other things T cells do, but just for the moment, let's just stick with those two functions. And next slide. And so if you think about the way that, again, very simplistic way of the immune system functioning, you have these things, the purple thing in the middle called antigen presenting cells, which means they go around and they find things that don't look like the body. They identify foreign invaders. And typically that's proteins, it can be parts of cells, it can be all different kinds of things that these APCs come about and recognize as foreign. Once they recognize it as foreign, they basically take it into the cell and then they present a part of it on the outside of the cell, kind of like a billboard. So they're now walking around like this bright flashing billboard to the rest of the immune system saying, hey, this is something foreign. We're under attack, and this is what it looks like. And then these two cells, the B cells and the T cells, start to mobilize. And the T cells will start to say, okay, well, I recognize that protein. I see it on this cell over here. So I'm going to go kill that cell and basically walk around killing all the cells that look like they may be infected, or, in the case of bacteria, the bacteria itself. The B cells, meanwhile, are sending out this stream of antibodies. They're these little Y-shaped things. And they basically block receptors to keep the virus from being able to latch onto cells. They can also latch onto cells that are infected, as well as things like bacteria, and identify them for T cells to then walk around and kill. A little hard to visualize, but basically B cells make a lot of antibodies. You'll hear about antibody production a lot when we talk about vaccines and vaccine response, and T cells kill cells. That's important because what we want is we want both of those cells to really get mobilized. When you get, so one of the things that's been approved is this monoclonal antibodies. That's actually taking the antibodies, or an equivalent, it's made in a lab, these antibodies that the B cells would make, and just inject them into the body without the need for any of the body's cells to make them. They can then attach to cells, block viral binding, and potentially kill cells. That's basically trying to mimic what the body's immune system does without having to activate the immune system to set up for that. So let's go to the next slide. So let's talk about how vaccines work then. So that's how the immune system works in the wild, right? When the body's attacked, when the body's infected, those cells mobilize, identify a particular protein or multiple proteins, and start attacking it everywhere it can find it. So what we do with vaccines is we try and simulate that. We give the body something to go after that's not an actual true infection. But it sets it up so that when you later become potentially infected, the body's already seen it and is already able to pump that stuff out right away. I should mention that process I showed in the previous slides takes some time. That's why when you get infected, you don't immediately stop the infection. It normally takes days to sometimes even weeks to fight that off. What we're trying to do is give the body a head start, a sneak peek, so that as soon as those proteins show up again, the body goes out and kills it quick before the infection has a chance to set up. So in this case, in the Pfizer and the Moderna, these are mRNA vaccines. So like a virus, this is just some genetic material inside a little fat thing. So that sounds exactly like a virus, right? Except the genetic material isn't a blueprint for an intact virus. It can't replicate itself. All it does is replicate a protein, and in this case, the spike protein. So what it does is it co-opts cells, it turns them into factories, just like viruses, and it has those cells pump out the spike protein. But it's only the spike protein. It's not the full virus, so it doesn't have a chance to infect other cells. The number of little particles of mRNA is the maximum number of cells in the body that can become co-opted. They're not really infected, they're just co-opted. But what happens is the body is now making this spike protein. That allows a lot of different attachment points for the antibodies. So the antibodies don't attach just in one point. It sounds like at least 6 points on the spike protein. You don't have to deal with some of the issues of other viruses where this keeps replicating in the body. So for instance, somebody who doesn't have an intact immune system or is taking drugs to suppress their immune system, this is safe because it's not going to take over the body in any way. It's only going to co-opt a certain number of cells. So then once the spike protein is out circulating in the body, all of a sudden that's recognized as foreign. And the whole immune system then kicks into gear. So the B cells and the T cells are both showing up and attacking those proteins. When the immune system does that, it acts like people will think, well, I guess I've been infected because I've got a fever, I've got body aches, or I'm fatigued. It's just like I'm infected. And it kind of is, because all those are symptoms of the immune system ramping up. So if you get a vaccine shot and afterwards you feel like crap, and maybe you run a little low-grade fever or something like that, that's not a bad thing. It's actually a good thing because it means your immune system is functioning and it's revving up. And what we want, especially for coronaviruses, they're tough to maintain immunity to. We want a really robust immune response. Next slide. So this is how vaccines are basically developed. And we talk about phase 1 through phase 3 trials. It gets a little confusing, but basically phase 1 trials are healthy volunteers. You give it to a few people and you see, does anything horrible happen? Do they grow a third eye? Does their arm fall off? Do they die? If they pass that basic safety test, then you can move on to the phase 2 trials, where now you've recruited hundreds of people. You now inject them with a vaccine. Typically it's several different doses. And then you follow them, first of all, to make sure that they're not getting bad reactions. And second of all, you're typically drawing antibody levels in the body. Now, we don't have a perfect marker for what means immunity in the body. So we know that we believe that if you make a good antibody response, you're more likely to be immune. But we don't know that for sure. Those are all proxies. But that's what the phase 2 trials are. And so when hundreds of people do that, you find what you think is the effective dose based on your antibody markers, and then you move to the phase 3 trials. Now we're talking thousands or tens of thousands. And the Pfizer and Moderna, they're both in the 30 to 40,000 range in people who were in the phase 3 trials. And they were typically split. One was split half and half. The one had a smaller group of people who get placebo, that is a non-active shot, and those who get the vaccine. And then the phase 3 trials, you don't know how long they're going to take because you're basically waiting for people to get COVID-19. Now, it happened to hit at a time when we had a huge outbreak. So we could quickly get to the numbers needed to show that the vaccines were very effective. In fact, incredibly effective for vaccines, much better than we expected. And 95% is the number, 94 to 95% is what we're seeing. We also get an idea of safety because now you get into tens of thousands of people, and we did not see any significant adverse effects. The only thing that we would note is that there's probably a little bit more fever and body aches and fatigue after the second shot than what you expect with the flu shot. But it's not significant and it's not dangerous. So then you get approval, either an emergency use authorization that the FDA gives, which is what both of these vaccines have been approved under, or you get formal approval, which will probably happen later this spring, would be my guess. But the testing doesn't stop. And in fact, all the people in the trials are still being followed to try and get a sense of safety and also to get a better idea what the long-term immunity will be with the shot. Next slide. So let's talk about some of these questions. So does it keep you from getting infected? This is an unknown with the 2 mRNA viruses, with the Moderna and the Pfizer vaccines. I keep saying viruses instead of vaccines, and I apologize. So what we know and what we were testing for in the phase 3 trials was, does it keep people from getting sick? And does it keep them from going to the hospital or dying? And what we know is that it's tremendously effective at stopping people from getting seriously ill. In fact, in the 2 trials with the tens of thousands of people, there was only one person who actually got the active vaccine who had what we call severe illness. But even though it met definition of severe illness, they did not require hospitalization and they had no long-term effects. So it's contrasting that to a number of people in the placebo group who were hospitalized and ended up in the ICU. So it is tremendously effective at disease immunity, that is keeping you from getting very sick. What we don't know is, did some of the people who got these vaccines still get infected but just not show symptoms? And if so, could they spread it to other people? We don't know that yet. Now, the AstraZeneca, which is currently in phase 3 and being considered for approval, actually did that testing, and it found that that particular vaccine, which is a different kind of vaccine, actually did an excellent job at that. People were not spreading the disease and not getting enough viral load to be able to spread if they got infected. Those studies are ongoing now and will probably be available through the spring, but we just don't know yet. And the corollary of that is, for now, even if you get the vaccine, if it's the Pfizer and the Moderna, you still need to wear a mask because you might still get infected and spread it to other people. My guess is you probably won't, but we just don't know that for sure. The next question is, how long does the protection last? And we don't know. The short answer is we don't know. We believe that in general, natural immunity, that if you get infected and recover, that you probably have very good immunity for at least 3 months. It probably lasts longer than that in most people, but we're certainly seeing people who are getting reinfected in the 3 to 6 month range. There is good reason to think that the vaccines will provide better and longer lasting immunity than a natural infection, partly because the proteins actually get into the bloodstream, which is where a lot of the immunity happens. Since COVID-19 is a respiratory virus, it tends to stay in the respiratory tract, in the upper respiratory, in the nose and the mouth, and down into the lungs, but typically doesn't get into the bloodstream very much. And so that's probably part of the reason why coronaviruses, why you can keep getting infected by them over and over again. What are the adverse effects? So the most common is pain in the arm. About 50% of the people will have a mild pain in the arm. Some will have more significant pain. And then it's kind of body aches, fevers, generalized fatigue. Typically that happens about the second day and it lasts for 1 to 2 days. There have not been any significant severe adverse effects, with the exception of allergic reactions. There have been a number of anaphylactic or allergic reactions. These have been relatively rare. They're more common than they are, for instance, with the flu vaccine. But as of about a week ago, when we'd given about 2 million doses, I think there'd been 11 severe reactions. All of them, from my understanding, were treated and released. So it's typically spending several hours in the emergency department, which isn't nothing, but it's not that people were dying or end up in the ICU. And that gives you a rate of about 1 in 190,000 vaccines. Just for comparison, that's roughly 20 times your lifetime risk of being struck by lightning. So if you're not that worried about being struck by lightning, you're probably not that likely to get one of these severe reactions. But there are people who have had severe allergic reactions in the past that are probably at higher risk. So if you carry an EpiPen around for severe allergic reaction, you're probably at higher risk. And there's a risk stratification to know about whether to take the vaccine. Are there long-term effects? We don't know. I mean, the bottom line is all this is new. The vaccines have not been around long enough to even understand that. There is no clear indication that there is, and there's no strong reason to think that there would be, but we don't know. But we do know that there are likely long-term effects from COVID-19 infection. So we know that there, in addition to the respiratory problems that we all heard about and having to be put on a ventilator if you get very sick, there are cardiac issues, heart issues, and we've seen that even in young, healthy athletes. There are probably neurologic effects. We don't know what the long-term effects of COVID-19 are either. But if you're a betting person, I would bet that you're much more likely to have significant long-term effects from an infection of COVID-19 than you will from any vaccine. Next slide. Okay, so that's my quick questions, quick question and answer. I think we'll do a little bit more longer. I'm not sure exactly how long I went. But what's really important is I really want you to hear now from Mindy Waldron. Mindy's our department administrator. She's the one who makes everything run and makes the trains run on time and knows the details, which she is coming up with right now about how we're actually going to roll out the vaccines. So, Mindy?
Thank you, Dr. Sutter. All good info. I learned a few things on vaccines, so that was always helpful for me. So I appreciate all that you shared with us. I wanted to talk just a little bit about the vaccination process, how it would work here locally. That's what a lot of the questions seem to center around: when, how, and what will happen for me. So I want to talk about how it'll work a little bit. So the plan, we'll just talk a brief bit about the plan. Mass vaccinations are not new to our department. We have done them for years. We've had, some small to medium and very large responses, even to the tune of hundreds of thousands when we did H1N1. So the process is not new. It's just the logistics. So currently, hospitals are conducting the phase 1A vaccinations now, mainly focusing on healthcare workers, especially those frontline healthcare workers, as well as then first responders, and some of those folks were added just as of yesterday, again, looking at more front-facing first responders, those that deal out in the public with folks and have to actually be close to them, or those that might handle infectious waste. So right now, those are the only folks that are prioritized for vaccination, and then it'll move into a number of different phases, and the health departments across the state and across the nation will step up in the next week to 2 weeks to start their sections. We will then do mostly essential personnel, and we will always pick up every phase that grows. We will pick up anybody that was not vaccinated earlier on, such as other healthcare workers, someone that maybe was on vacation, didn't have the chance to do it, other first responders, and then we'll move through other prioritizations given to us. So as those are prioritized and we're told of those, which is very much in real time, we don't have an advanced list saying next on the list is X, Y, and Z. We don't have that yet. So we are told in real time who is next, how many those are, and how we are to kind of target those. And then as we move down the line, we'll move into some age groups or certain conditions or those types of things that will prioritize people higher based on risk. And then we'll get to the general public, which will take a large part of the time, but that likely won't be for a couple months. And that's always hard to hear. So we'll do them in one central location though, and we will have daytime, evening, and weekend hours as the hospitals do now. So what will in essence happen once the health departments come online, then there will be some hospitals that may stay and continue with doing mass vaccinations for certain groups. So there'll be choices as to what's closest for you and has the best schedule. Most things will be done by appointment, which is very different than anything we've done in the past. It's kind of like if you were tested by us or any of the sites that we ran, everything was done by appointment for the most part, where you had the opportunity to pick your time, do the pre-registration, answer all the questions to save you time once you arrive. So we will have an online system very similar to what we've had for our testing sites. These are all run by the state. These are required. We do not have a choice as to how we do this. And we will also, because what we learned is not everybody can navigate that online registration system. Not everybody has a smartphone, for example. So we will have a phone line call-in option to make appointments through our staff and to ask questions. So we're working through the logistics of that. And we'll do it for as long as it takes. So we are looking at likely at least a 6-month process where we will start very soon and go until everyone has had the opportunity to be vaccinated. And then we would likely do what we do with other vaccines, which is kind of implement them within our vaccine clinics once we get down to a trickle of folks that are left. So we estimate that we'll start here soon and likely go about 6 months. Could be quicker, could be shorter. So we will conduct them 5 days a week once we get going in full force. What we learned yesterday and what we all have to remember is what we say today is as of today, and it may change at any moment. When we did these slides 2 days ago, it changed yesterday. So we will be starting with a very low amount of vaccine, and that's normal. We expected that. There's a lot of vaccine that's spread out across the country, so we'll be starting low and then we will move up. So likely the first 3 to 4 weeks will be fairly slow for us, where we'll do prioritization groups and maybe not a lot of them, as much as we're prepared to do. And then when we get into full force, we'll have multiple days a week, 40 to 50 people plus working at the clinics each day to move things as quickly as possible. So we know that the vaccines will be free. There will be no back billing or charging to patients, but we will be gathering your insurance information as the state will bill for the vaccination administration fee to insurance providers or payers, but there will be no charge to you and there will be no back billing should the insurance not pay. But what you'll want to bring, and this is really important, and we'll try to message this whenever we start putting out lists of who is prioritized and where you can go, is we will have to identify you. And so we've learned over the last couple of months that a lot of people have either lost or had stolen their ID, or they don't bring it with them when they come. Be sure you do. This is a vaccine that you will want to have a record for having been given it in all of the systems. So we will need to ensure you are you. We will also need your insurance card, and we will require that you wear a mask. If you don't have a picture ID, which we do understand there are some extenuating circumstances, we'll need other documents such as a birth certificate, social security card, along with some utility bills and such. And then we will need to ensure that we have verified that is something we have to attest that we've done. And then the thing that we will do also when you arrive is we will schedule that second vaccination for you at approximately 4 weeks out. So that's already on your schedule, and you know that we're holding vaccine for that. So we're working with other partners as we move down the line after all of the larger groups are prioritized and sent to mass sites or hospitals, however folks chose to be vaccinated. But we know we will have other populations, such as those that are homebound, those that live in or are in and out of confinement settings, some other vulnerable populations who may not be able to traverse quite as well to a mass clinic, and then maybe going into certain areas of the community to provide the vaccinations. That just will not be possible at the outset, but we have plans with other community partners who are willing to assist with those things and can go a little bit mobile. It's important to realize that for vaccines right now for COVID-19, they will not be provided by your general physician. They will not be at ReadyMed, any of the stat care type facilities to start. To start, it will only be hospitals, and then pharmacies who are assisting with long-term care vaccinations of their clients, as well as some of their workers, very high-risk population, and then health departments. So we cannot transfer the vaccine to schools or other large businesses, even though you may have a health clinic. Down the line, though, we hope that will be a possibility to help kind of move the flow or get it out quicker once there's more vaccine to work with. But initially, it will only be those 3 types of entities. So for the most part, you'll be going to a hospital or more likely to any health department site throughout the state that they deem to open at the time that we're allowed to do that. So we will work with others to get through some vulnerable populations a little bit later down the line. So what should you expect? And just briefly, because people do ask, well, what is it like? What will happen? And it's very similar to any vaccine that you've had. It might just take a little bit longer due to the observation requirement that we have. So our check-in process is estimated to be at about 10 minutes. And we hope that it'll be a lot quicker than that if people pre-register online and move it quickly so there are no lines. We will pre-screen you as you arrive to ensure that you don't have anything that would kick you out of being eligible that day, such as if we're doing groups, prioritizations, we have to ensure you are in that prioritization group. We'll ensure that you have an appointment. We'll make sure that you don't have any allergies to the vaccine ingredients or anything that we're cautioned against giving the vaccine for. We'll ask a few health information questions, such as Dr. Sutter mentioned, do you have a history of pretty severe anaphylactic shock, or have you had any type of reaction to a vaccine in the past? We'll ask those questions so that we can help gauge whether you should proceed with the vaccine. Most people will proceed beyond that. If there's someone we can't answer their questions or they seem to have some pretty high risk, we may recommend that be given in a hospital. So that would be very rare, but we will have folks and be able to reach folks that we can get those answers. For the most part, once you make it through the pre-screen process, which would really only take about a minute, we'll get you to our intake stations where we will do the ID verification. And if we're prioritizing folks by age, so should it be a group by age that we're doing, we'll need to ensure that. So we'll need to see something that identifies your actual age, date of birth. We'll check on your demographics to make sure that what you entered is correct. We find a lot of times there are input errors, both on our side as well as the public side. So we'll verify that so that your record is complete. And then we'll, as you do with any vaccine, we're going to ask you some questions about your history at the time. So are you ill today? Are you experiencing X, Y, and Z symptom? Because we don't want to give you a vaccine if you're already slightly compromised. Just like when you get the flu vaccine, they ask you, do you have a fever today? Have you had a certain type of vaccine just recently? We're going to ask you those things as well. We'll also have this information on our website soon, so you know what to expect, what not to schedule if you've just had, and how you can be vaccinated. So we'll keep that very at the public's eye as soon as we're ready with that. We'll complete some consents. Now you'll be able to do that in advance as well online, but if you haven't done that, or if you have questions for us, we can do that in real time. Those are all electronic. So there's not a lot of signatures, not a lot of touching things. So most things will just be Q&A. You will have pre-done it, and then we'll work through it in our system. And then, like I said, we'll schedule that second dose for you so that you can pick your time, and we'll give you a card, a reminder for that. And then we'll also give you your vaccine record card that will be noted at the time of the vaccine in the back part of our clinics. We'll answer any questions through any stage that we put you through. Vaccination itself should be relatively quick. So they will just verify that they've got the correct record opened for you, answer any of your questions that maybe you didn't have answered, and then they'll conduct the vaccination. We're hoping to achieve about a 3 to 4 minute vaccination interaction. Very quick, in and out. They'll then move you to the observation station. Now, in most vaccines, you don't have to sit and be observed, but with COVID-19, relatively new vaccine, not a lot of experience with it, and it is required that we observe you for 15 minutes. So we have a large area, socially distanced, with a lot of information that will be in front of you so that you can read it, you can sign into things to talk about if you do have reactions, and we'll have folks there watching you. And you can raise your hand if you have any issues or questions, and we have an area where we can treat folks should there be any reactions. So in general, most people will be observed for 15 minutes, and you'll sit there. We'll be there to answer any questions or treat you if there's an issue, and just ensure there's no reactions, which for the most part, there likely won't be. Answer any last minute questions that you have. And then, like I said, we have an area should we need to treat folks. It may be longer for some people. So if at the pre-screen process, we determine you do have a history of allergies or things along that line, but you want to proceed, we will be able to attend to you most likely, but we will ask that you stay a little bit longer so we can observe you for a longer period of time. That would all be shared with you upon arrival. So total, probably 25 minutes on site if we're moving flawlessly, maybe 30 minutes total, but we hope even to get it down to a 20-minute total over time. And it'd be about 40 minutes for those that might require that 30-minute observation. So for in general, less than 30 minutes in and out. And then we'll see you in about 4 weeks. So we have built a site that we hope to be able to do 120 to 140 an hour. We will start out very slow though. So we might be starting in the 20 to 30 range because we are highly dependent on the amount of vaccine that is shipped to us. So the amount of vaccine that comes to us, we will work a way to get that out the door within that week. That's how it'll work. We'll get very quick notifications, usually only in about a week in advance. So we won't know much about what our appointments will look like until we get close to that week prior. And then we would announce things. So as I foresee it happening, now we're working through prioritization groups that we're told and usually have certifications or licensure. So they're receiving emails, they're being told by a state entity or Homeland Security or IPLA, the licensing agency, saying this group is prioritized, you are eligible, you can make your appointment. As it moves down the line, there won't be email lists, and it will likely go out through the media or through our website, number of ways to communicate to folks in the public who is next in line. And again, we don't have that list, but when we do, we will post those. Then you will make that appointment. We will see you, answer any questions. But again, it's going to be dependent on how much vaccine is shipped to us. So hopefully that gives a little bit of an idea of what to expect when you arrive, how it might work as far as us notifying you, how the vaccine itself works, as Dr. Sutter explained, and then we'll get into a little bit of Q&A here. John?
Mindy, Dr. Sutter, thanks for that great information that you provided to us. I know I learned a lot from it. We've got a number of questions that were submitted with registration, and then also the Q&A function is available at the bottom of your screen. We've got a number of questions already submitted. So we've got another 20 plus minutes. We're going to focus on the Q&A. We'll start with some of the ones that were submitted ahead of time. When will food service workers be able to receive the vaccine? And that's probably frontline in general. When you think about the retail sector, an area that has been working through the pandemic. Can you address that question?
Mindy, do you want me to take that one?
Yes.
Okay. So, I mean, the short answer is we don't know. The the important thing, you can see the answer on the screen here. Currently, ACIP had classified or made a number of different recommendations as to how to roll out the vaccine. Those were strictly recommendations, and each state is making their own decisions. And in general, the states are choosing things different than that. Indiana has not yet announced what their 1B is going to look like. We know that it includes police and fire because that went out yesterday. There is a good chance that they will know. I'm actually a part of the advisory committee to that, so I've been part of the discussions, but a final decision has not been made. But I do not think that they will follow directly ACIP's recommendations. So it's a balancing act about trying to decide what's the highest priority. Do we prioritize infrastructure or do we prioritize lives saved? Because they're different strategies. And then how quickly are we getting the vaccines? The goal is to try and match as much as we can supply and demand. Right now, we've got relatively limited supply and a tremendous amount of demand. And so what I anticipate is there will be groups rolling out from time to time, kind of quickly on relatively little notice, and probably not a lot of advance notice about who's next. So unfortunately, we can't give a good answer at this time about food service workers in specific, or really any workers or age groups right now, other than the ones that have already been announced. Let's do next.
Yeah, I think the next slide covers just a little bit more on that.
Yeah, so this is, again, from CDC based on ACIP's recommendations and kind of the, where we, based on how many doses per week we get throughout the nation, how long it will take to vaccinate those groups. Understand, though, the states make their own decisions. So this is strictly a suggestion, and it looks like the vaccine rollout has been less quick than what we anticipated. We actually, in December, I was really happy when the Pfizer was rolling out, and it seemed to ramp up pretty quickly, but Moderna has been coming kind of slow, and so our allocations have not been large right now.
One of the questions we received, and heard this a lot, I know there's discussion out there, can employers mandate the vaccine as an employment requirement?
Yeah, and I'm not the right person to ask. I'm not an employment law expert, and that's really what that is. I mean, I think the other question is it ethical for employers to do it? And I think that's premature, because that probably has a lot more to do with whether we can transmit the virus after we're vaccinated. And we just don't know the answer to that yet with the two vaccines that are out there.
And that's one I would say I would advise you to take up with your attorney, your employment law attorney. And we can work to get some more guidance on that and post that on our website as well. So we'll work on that piece. When you talk about herd immunity and getting to a point where we can lift the mask mandate and other restrictions, even with the vaccine, you said probably you're going to need to continue to wear a mask. What do we need to get to in order to get to the point where we do lift those restrictions and start to be able to remove that mask in public?
Yeah, so again, it's premature because we don't know yet whether Moderna and Pfizer stop transmission of the virus, whether you can still get it, be asymptomatic, and spread it. And if it's only disease immunity, but you can still spread it, it needs to be a really big number. And we need to get basically almost all our vulnerable people vaccinated. If it stops transmission, then that's typically, could be as low as 50%, could be as high as 80%. Experts disagree. We won't really know till we get closer to that number, but it's probably somewhere in that range before we see what we call herd immunity. The more infectious the virus, the higher that number needs to be. With measles, it needs to be, high 90s because measles is so transmissible. SARS-CoV-2 is not that transmissible, but it's more than flu, so it's going to be somewhere in between.
We've heard a lot about new strains of the vaccine happening in Europe, the UK right now. Have the new vaccines been tested at all against those new strains?
So the short answer is no, they've not been directly tested because it's too new. I'm still not calling this a strain yet. I'm calling this a variant because we don't know for sure whether this actually acts differently than the base SARS-CoV-2. There is some early indication that might be more infectious, but it's epidemiologic data. It's not the virology data yet. So Obviously it's been huge media coverage about this, similar to the spike mutation that happened earlier, the D614. We're still not sure whether that's more infectious or not. They're still doing that data. Even if it is, everything's still the same. You still have to wear a mask, you still have to socially distance. It might accelerate some outbreaks, but the answer to it is exactly the same thing as what we're recommending now. So it's not been directly tested, but there's good reason to think that the current vaccines will be effective because there's multiple sites on the spike protein for antibodies to attach to, and the body is actually making antibodies to those. So even if it changes in one spot or one series, it's likely that there'll be multiple other targets. In addition, one of the nice things about mRNA vaccines, which are new, and they're kind of a moonshot, is they're pretty easy to tweak. So if it becomes clear that there's a dominant variant, that the vaccine is not acting well, it's fairly easy to tweak that and roll out a new vaccine. Now, that's a huge undertaking, but it's not like we have to start from scratch.
I think the next slide probably covered just a little bit more of that. And then we're going to go to the online Q&A that has been submitted. And I'll just kind of go through some of those, kind of speed round here with Dr. Sutter and Mindy. You mentioned a number of times you don't know exactly how much vaccine you're going to be getting. Do we even know if you're going to be getting the Moderna vaccine or the Pfizer vaccine? Will people know which vaccine they're getting?
It's Moderna vaccine is what we'll be getting initially. We don't have the capacity to get the Pfizer vaccine because we don't have the ultra cold storage. So in general, the hospitals are getting Pfizer and the health departments will get Moderna.
Okay.
We anticipate we may get other ones like AstraZeneca and such later too as they become approved. So.
There's a question about how does the vaccine affect your DNA in any way? You talked about RNA. Is there any effect on an individual's DNA?
Yeah, there's no evidence that it affects the DNA. There's one preprint that suggests there could be an effect, but it was a lab study where they basically pumped things through of extra enzymes that converts RNA to DNA. Is it theoretically possible? It's theoretically possible, but in general, it doesn't. There's no convincing evidence. There's certainly no reason to think that it's any more likely to than the virus would be to incorporate itself into the DNA.
How do you see the COVID-19 vaccine interacting with the flu vaccine? So should somebody get the flu vaccine first and then get the COVID-19 vaccine? Should they hold off? Any guidance on that?
They should get the flu vaccine first because it's available. And in general, the COVID-19 vaccine is not going to be available for most people. So there is no direct recommendation. We don't really want you to get them at the same time just because it's not been studied yet. But while people are waiting for sufficient supplies of COVID-19, I'd recommend they get the flu shot.
Okay.
Hey, Dr. Sutter, could you also let them know about the recommendations such as people ask, should they get their shingles vaccine before or after? And what is that wait time? Would you be able to comment on that?
Probably. I think it's 14 days, and that's kind of a made up number. But in general, we just don't want to mix other vaccines with this. So we're asking that, if you're eligible for the COVID-19 vaccine, it's available, get that first and then wait 14 days on other vaccines. If it's not available, get your other vaccinations now.
Dr. Sutter, do you have any guidance for people that maybe have other immune suppression situations like HIV or cancer? Should they be consulting their family doctor or their specialist around those situations?
They're welcome to if they like. There's no reason to think that there's any downside to getting the vaccine with those conditions. It's probably better to get the Moderna or the Pfizer, those mRNA vaccines, rather than, for instance, the AstraZeneca, which does have a virus in it. It's not the COVID-19 virus, but it is it's an adenovirus, which is used to deliver the material. So somebody with severe immune system problems should probably not get an active or an attenuated virus. They should get one that makes proteins like the mRNA. So no adverse things that we're aware of. What we don't know is, will they get the same immunity from it? We just haven't studied it enough yet. but even limited immunity is going to be better than none.
Mindy, you talked about your website will have information up. Do you see that being a dashboard of how many people are being vaccinated, how many people you plan to vaccinate next week, who are the next groups up, things like that? Could you talk a little bit about that?
I think those are good ideas. I think we could establish some sort of a dashboard with some general data of what we've done to date and maybe what's projected, anything that we might be made aware of, such as the next group or how much vaccine we have any given week, because we're about the most transparent department as we can be. So as much as we can get out, we will share. And I think that's a real good idea. Simplistic bit of a dashboard just to give an idea, no problem there. And then we'll probably have some links to other information that's helpful for decision-making for folks. I would project that that will be 1 to 2 weeks out before we would have enough information to even put on a dashboard, but those are great ideas.
Thanks. And you referenced earlier that people right now are maybe receiving emails if they're in a group that is based on a licensure or things like that. But for those of us general public, we're not going to get an email. Like, we're going to need to watch out for the press releases, watch out for the news, watch for notifications that it's time for us. Is that correct?
It is. I mean, currently, as we know, it will roll out in a way that these first few phases are mostly folks that will get some sort of a notification. After that, it will be done via the media or websites or other social media. We will widely post that, as will, I'm sure, the state, when we need to do it, where we notify people by watching media. And so that is exactly how it will happen. And then, like you said, if we could post anything that we know that gives people notice, as long as we have notice, we'll give you notice. But what we have learned so far is it tends to roll out based on how much there is available that week. And then they say, let's target this group. So that's probably what will happen until we get to the larger groups where it's more mass, as they do what they're calling them sub-prioritizations. So when they say, for example, essential workers or first responders, within that, there are sub-prioritizations where they'll say something like, meaning the frontline workers, those who do X, Y, and Z, not the ones who do A, B, and C. So they are just trying to break it down so there isn't such a mass response for appointments when the vaccine amounts are low. We knew this would happen, just so everyone knows that this is not concerning. This is just how things roll out when they're new. And even with H1N1, it took well over a month until we were in the thousands range. It would be hundreds that we would get. And so it's very similar. And unfortunately, it's just about playing that game of patience. And we know that's very difficult. So we will do our best to get info out as soon as it's gotten to us.
Thanks. And you mentioned your website. Could you maybe give everybody the link to the URL to your website?
You want me to put that in the chat? Is that what you mean? Or just, it's really easy. It is just allencountyhealth.com. So most people will do the www.allencountyhealth.com.
So allencountyhealth.com is the best place to get the health department's information. That's where they'll be posting information. There was a question about your thoughts on the FDA's considerations in giving only 1 dose or a half dose of the Moderna vaccine. Is there any negative consequences to that?
I haven't seen anything about half dose. I have heard consideration of 1 dose and delaying the 2nd dose. The downside is it hasn't been tested. We know that there is some immunity from the 1st dose. But it seems like you really need the booster to give you that extra shot to really be able to stop infections. So, that just becomes a risk-benefit analysis about do you vaccinate more people less well, or do you vaccinate fewer people better? We'll wait to see what they have to say.
Mindy, this is probably a question for you. You mentioned about having a photo ID, insurance card. How will children be handled without a photo ID?
That's a good question. And currently, Pfizer vaccine is approved for those that are 16 and older, and Moderna will be 18 and older. So most likely, those folks are going to have some sort of ID, driver's license. If they're under 18 anyway, they do have to be accompanied by a parent or a legal guardian. And we've had situations where folks couldn't get away to get their child to get tested. It'll be very similar for vaccine. They will need to fill out a form that indicates someone is kind of appointed as a temporary guardian. We have a process for that. That will also be on our website. So what we will list is something similar to how we do it for birth certificates, where we'll list, here's what you need to bring, and here are the options if you don't have the driver's license. So we'll list those sorts of things. For children, as we move toward that, it'll be more about getting consent from parents. That may not be done in a mass setting. I imagine some will be, but that might be where we partner with others and we do it in other areas. So we'll do it much like we do for any other vaccine, where the parent will attest for their age, possibly, there'll be other records that we'll need to see since this is a different thing, but very similar process where it'll mainly go through the parent or the guardian.
Okay, thank you. You both mentioned that a lot of this is dependent on what the state decides. That states have the opportunity to set priorities, set guidance. When do you expect kind of the state to finalize their plan for the vaccine rollout?
We don't know. We're finding it out in about the same time as everybody else. There's discussions ongoing, and I expect there will be an announcement this week. Probably tomorrow would be my guess at the weekly press conference about the next group. But I don't know that they're going to commit to a long-term plan of the exact rollout. I think they're preferring to continue to watch trends and have discussions, because the supply is it's just not well known how the supply is going to be. So I think the idea is we figure out what the next group is, we get to at least a 40% rate of that group, and then we start opening up to the group after that. So not every group needs to be fully vaccinated before we move on. The goal is reduce the number of open appointment slots. Get all the vaccine we've got and get it into arms, but don't create a situation where we have a tiny number of doses with hundreds of thousands or millions of people trying to get access to those limited doses. That's the crux. So it's really an operations problem.
The next question, I know you're not ready to answer, but I'm going to ask it anyways so people can understand. As far as where you're going to do the vaccinations, when do you expect to announce? We talk about mid-January. That's here in just another week or two. When do we expect to start to announce where we're doing the vaccinations and things like that?
And it's a good question. And for security reasons, we're just keeping that a little quiet for the next few days. I would envision that by early next week, we will announce most everything via press release indicating where things will start, where they'll be, and how our plan will work. And we'll kind of announce how we will notify people, and kind of the things that we've discussed today will likely be the contents of our press release. And at that time, so with less than a week, we should be announcing our exact site. What I can say is it's centrally located, and it's large, and it should have great opportunity to move people quickly. So we'll announce that very soon.
Okay. You mentioned earlier about kind of keeping your health record, making sure that you can prove that you've had the vaccine. Has there been any talk of an app or anything that is going to be kind of a national clearinghouse that we'll be able to have to prove that we've had the vaccine? Or how are we going to, if I need to prove that I had it, how am I going to do that?
There's a number of ways, and we will give a bit of a remedial way just so you have it when you leave. It'll be a card similar to what we did in H1N1, two-sided card, indicates where it was given, what was given, the lot number, all of those things. That's a quick way to have it with you, and you'll bring it back for your second one. But what we enter into the state's database for this also feeds into what is called CHIRP, and that is the immunization registry that all vaccines are in now. So you'll have access to that because we have the availability to, and we've done this, we do it now. You can get access to your record. So you can print it at any time, and this vaccine itself and both doses will register in there. So it will be along with, if you're familiar with needing to get access to your immunization records through our system now for children for school, it'll be just like that for adults. Everything will be in one system. And we will probably explain down the road just a bit how you can easily get access to that to have it in a full list. Right now, until that is fully tested, what you'll get is that card. So you'll have an immediate record, but then your long-term record will marry up with all the other vaccines that you have had in that CHIRP registry, if that helps.
Thanks for that. We've got just a couple more minutes here, a couple kind of specific questions I guess I'll ask probably Dr. Sutter. a question about if somebody has a DVT, should that person wait to be vaccinated?
So yeah, DVT is not on the list. Really, the only contraindication right now to getting the vaccine would be a specific allergic reaction to one of the components of this vaccine. That's the only ones that we will not vaccinate. Everything else is a risk benefit, but DVT is not on any of the lists that I'm aware of.
Okay, and you mentioned some of the allergic reactions. If you kind of said if you carry an EpiPen, you should maybe perhaps have more of a conversation about it. How about things like reactions to iodine or things like that? I assume that's what the 25 to 40 minute kind of evaluation after the injection is for.
Yeah, so again, there's been so few so far that I don't know that we have great data on this, but in general, things like bee stings and contrast reactions would not be somebody who would be thought to be at extraordinarily high risk. Now, anybody who's had a severe allergic reaction is probably at some increased risk, but that risk is probably pretty small. In contrast dye would not be ones on the high risk list.
I'll throw out this last question. I guess Parkview has announced it's moving to 1B. Is that, you mentioned earlier that police and fire are now being notified. Is that part of the moving to 1B? When will others in that category, like critical manufacturing or others, maybe start to get notification that they're eligible?
Yeah, so critical manufacturing, I believe, was part of ACIP's 1B recommendations, but it's all based on what the state decides in terms of where they'll be in the list. So just because they were part of the national recommendations, I would not assume that they are going to be the next people vaccinated. And the short answer is we don't know. We got to understand what our allocations are, what the state's allocations are. Essentially, all the vaccine has been bought by the U.S. government and then allocated to the states, it's rolling out relatively slowly.
The only thing I would add to that is when the hospitals were notified that the next group that was going to be prioritized were the first responders and some of those folks, they then started reaching out to them as well. So I don't know that we're at a point where it's been said, hey, we're actually moving to 1B and it's all of these groups. What happens is that when there is the availability of vaccine, they want to keep moving. They don't want to have it sitting. So when they do that, they'll say, who's next? So it's not just that the hospitals moved there, they just had the availability to start vaccinating those next groups and being able to move people forward, where it was early on anticipated that that would be done by health departments. And that's probably what will happen here, but it's a very good thing. They're moving people up quickly. So we'll probably see that as we go these next months, where if there is vaccine, they'll probably move people up on those lists and say, let's get it out to more folks. So I don't know that there was a significant move to 1B. There were just the next group saying, hey, let's start getting these folks done because there is vaccine for it. And it was prior to health departments opening, because we were told, because we can't do Pfizer. They've still got Pfizer, it's still coming, so they could start rocking and rolling with that. Whereas we had to wait until we get the Moderna, and it's not here yet, but it will be here soon. They didn't even want to wait a day. So they said, hey, hospitals, start reaching out and you can start doing these folks too. So that's how it'll roll out. And that's a very good thing because it gives people options for locations and times, and it gets them done quicker. So it's a very good thing it happened.
One last question. It's kind of a follow-up to the allergic reaction question. You mentioned if there's been a reaction to one of the ingredients in the vaccine. Is that list of ingredients something that can be posted on a website? So before they even schedule a time and come out there and take up a slot to get vaccinated, they would know, okay, maybe I'm allergic to whatever one of the ingredients is in that vaccine.
You know, it's a really good question, and I've not seen that list. Basically it's the nanoparticles plus the mRNA. There aren't a lot of other ingredients like the aerosol or other things that people have mentioned in other vaccines. I suspect both the Pfizer and Moderna websites may address this, but I've not seen a specific list.
Okay, well, thank you very much for the information you've provided with us today. Again, I want to thank our panelists, Dr. Matthew Sutter and Mindy Waldron, for all the information that they've provided to us. for the questions that they've answered. Thank everybody, thank all of you for joining us today to hear this information. Again, you will receive an email following this webinar for a survey to let us know how you felt the event went. A link to the recording of the survey. Feel free to share that with others that you think might be interested. We'll also be hosting that on our website so that more people can hear about the vaccination plan here in Allen County. I think the goal today was to make sure that you understood that what is out there as far as information regarding the vaccine, and assure people that Allen County and the Department of Health have developed a significant, well-coordinated plan for mass vaccinations that will be rolling out. Continue to wait for more information. I know they'll be putting that out publicly, and we will be helping them get that out. So there was more to come, and as Mindy has said, it changes daily. So we'll continue to make sure that you have the latest and greatest information. So thank you both for your presentations today, and thank everybody for joining us.
Thanks. Have a great day.
Thank you.